Submersion emergencies. So drowning is respiratory impairment resulting from the immersion of a liquid, immersion in liquid. So older terms, you may have heard in drowning discussed before: dry drowning, wet drowning, near drowning. They're all kind of describing different versions of the same thing. So it's just been simplified now. Just drowning is respiratory impairment from immersion in a liquid. So people still do drown in Australia. We've got 25 million people and about 280 drowning deaths, which isn't, much out of 25 million. But this third point's worth noting. So drowning deaths are preventable and they tend to have high years of life loss. So it's often healthy people who had potentially a long future ahead of them losing their lives from drowning. And it's often thought of as a children's disease, but adults actually drown far more often than children do. So there's no set etiology. People drown in pools, they drown in shallow water, deep water, on beaches, out on boats. And many include foreign visitors. We kind of take it for granted in Australia because almost everyone lives on the coast. Everyone's taught how to swim, but that's actually not common overseas. And a lot of visitors want to swim at our beautiful beaches, but are actually not strong swimmers or don't even know how to swim. So when someone does drown, regardless of how it occurs, the same process is always followed. They initially try to hold their breath for as long as they can, and they can't hold it anymore. They'll try and breathe, but laryngospasm will occur. When that laryngospasm is finally broken due to hypoxia, larger amounts of water will enter the lungs. The person falls unconscious, they become hypoxic with the associated acidosis, and if that's not corrected, they have cardiac arrest. Now it's important that that the person can be removed from the water at any stage in that. They're not always going to be in cardiac arrest when they get pulled out, depending on when they're found. So you'd sort of think intuitively that if someone gets pulled out before this part, before lots of water enters the stomach or lungs, that they would not have water in their lungs. But almost any time someone has a submersion or drowning event, if you listen to their lungs, you hear a lot of crackles. And the reason, and this used to be called dry drowning, is that if you have a closed glottis from a laryngospasm, but your lungs are desperately opening and trying to pull air in, you're going to be generating enormous negative pressure in your chest. And you'll actually pull water in from your alveolar capillaries into your lungs. So you're still getting water, you're still getting APO basically, but not from an external water source. You're getting it from an internal water source. The reason we don't make a huge distinction there is that water is water. If it's impeding gas exchange, it still counts as drowning. And just this bottom point, much has been made of the difference between salty water versus fresh water versus clean water. Makes zero difference for us pre-hospitally. That will be an ICU problem. There's absolutely nothing we can do about it. So just don't worry about that. So when someone has a drowning event, they will either have laryngospasm or aspirate the water after the laryngospasm fails. Now, this cold water section, this is for, the Arctic Circle, Norway, Finland, Russia. We're going to, in Australia, even, our cold water in like the Victorian Highlands is still not that cold. So we're going to be looking at the warm water. So laryngospasm or aspiration, hypoxia, death, and we're probably not going to get any of this neuroprotective brain cooling from being submerged in, sub-zero water for extended periods of time. So because people can get pulled out of these drowning events at any stage in that drowning process, the presentation is really variable, ranging from fully conscious to cardiac arrest. So you're going to rely on the location of patient. Obviously, this person in the picture being pulled out of the ocean, you can suspect a drowning. If they've been, in a pool and been swimming, to suspect that they may be a drowning victim. So the focus of treatment is on oxygenation and ventilation, and other interventions. So the focus of treatment for drowning is oxygenation and ventilation, and no other interventions should delay that. So if you have a patient who's conscious, you want to oxygenate them. Now, if they're able to tolerate it, this will just mean a non-rebreather mask. If you can't get the SpO2 up above 94% with that, or if you're listening to their lungs and they're very, very crackly and it just seems like it's not doing the job, you may need to switch over to CPAP. So we often think of APO as cardiogenic APO, but APO just means, pulmonary edema just means water on the lungs from any source. So if that water is from an external source, CPAP is going to work just as well to prop those alveoli open and increase gas exchange across them. So if the patient is unconscious, you're going to have to get as much fluid as you can out of them. So roll them, drain the fluid. You want the patient to be supine. There has been research on different positions. Whether you want them head down was a thought for a while because it will passively drain fluid. Really, that just increases stomach regurgitation. So supine position is preferred. You want to ventilate them with a bag valve mask and consider an early LMA or intubation to increase the amount of pressure that you can put down through that into their lungs from ventilating them. Now, if they are in cardiac arrest, it's normal resuscitation with some changes. So normally when we do CPR, ANSCOR recommends a decreased focus on ventilation. They want it to be all about good compressions and good blood circulation. But in drowning, we have a very reasonable suspicion that this is primarily a hypoxic problem. So there'll be an increased focus on good quality ventilation. So we're looking at a very early advanced airway and plenty of, really making sure that we're getting those breaths in between compressions. So like most traumatic causes, the rhythm will not be shockable. Most likely, you expect PA or asystole, and you deal with patients who've aspirated a lot of water. They will have frothy, like fulminating APO type froth coming up, or just frank water. You don't want to be continually stopping compressions to roll them. Just continue to suction it out. And because drowning is reversible and the history is usually not that clear on how long they've been under, exactly what happened, this is when you just want to start resuscitation unless there are clear signs of death, like the patient has rigor mortis. Now, you still see, I think even QAS still says that C-spine injury should be, assumed in all drowning victims. Like, in reality, use your judgment on that. If someone's been found at the bottom of a shallow pool after diving into it, absolutely that person probably does have a spinal injury. But if someone's drowned in deep water off a boat, what were they going to hit their head on? So use your judgment there. Putting a collar on does make the airway harder to manage, always, even a soft collar. And we know that the treatment for drowning is maintenance of the airway and good oxygenation. So I certainly remain unconvinced that the C-spine should take any sort of massive priority unless there's quite a clear indication for it, okay? Now these patients are going to be cool, more than likely. They've drowned, so they're going to be cool, covered in water. Although there has been research about targeted temperature management and therapeutic hypothermia, there's insufficient study in drowning to make a recommendation. So in the absence of that, the guideline is to just warm the patient to a normal temperature as best you can as part of your treatment and resuscitation. Now, if someone's been pulled out of the water fairly early in that drowning process and they're GCS 15 and they kind of seem all right to you after you assess them, you still need to transport them to hospital. So you can have something called secondary drowning, which is where small amounts of water that may escape notice on your initial presentation can start to cause problems if they've been aspirated hours to days down the track. So it's best to just take them up to hospital, and they'll generally be happy to go if they've had a near drowning, and just to get them checked up on and be sure.